In your professional life, what gives you the most satisfaction? Well, if you're Conan the Barbarian, for example, and someone asks you what is best in life, you might say three things: to crush the enemy, to see them driven before you, and to hear the lamentation of their people. Or if you're a geriatrician, you might say these three things: to stop medications, and to, Wright, stop medications. So I want to talk a little bit about something near and dear to my heart as a geriatrician, and that is stopping medications. And I would challenge everyone listening to this, if you are working with older folks in any kind of facility or in an independent living, and you're not taking the opportunity periodically to look through their medication list and see which ones you can stop, you got to ask yourself, am I really a geriatrician? The answer is, well, probably not, but you can become a geriatrician. You can start thinking like a geriatrician if you start thinking about how dangerous medications are to elderly people. And the way I like to think of it is, as you get older, especially as you're approaching your 80s and 90s, there's a lot of things that medications can do to you. But there are not a lot of things that medications can do for you as far as extending your life or improving your quality of life. And if we're taking a medication, we want to make sure that it is going to either extend our life or improve our quality of life, or do both. And if you don't have good evidence to back up your use of medications for those two objectives, then you need to think seriously about stopping those medications. So fortunately, we all have a list that we can use to help us to determine which medications to stop. And that list, of course, is the Beers list. Sounds like something you drink, but it's something you read and something you really internalize, and it should help you to guide your medication review. The Beers list, or the Beers criteria, is something that's been around since the 90s, and it helps geriatricians and physicians of all, and providers of all stripes and sizes and shapes and all of this stuff, to figure out which medications they're going to stop. So I'm going to, if I can figure out how to do this, I'm going to drop the link to the Beers criteria that the American Geriatric Society makes available free of use, so that you can click on it and look at these in more detail. But I'm going to break down the typical way that I approach stopping medications and talk about a few of the classifications on the Beers list. The most critical thing to look at, I would say, is if you are a person that's accepting a patient from another facility, especially from a hospital, and they've had some kind of medical crisis, you have to look at that medication list and see, is that medical crisis caused by something that we, as part of the medical community, something that we are doing to this patient? For example, if someone comes into your facility with a fall, with or without a fracture, with or without significant injuries, they come in because of a fall or multiple falls. Sure, rehab is really important in improving stability and gait and safety, but don't forget your role in looking through that list and stopping those medications which are shown to increase the risk of falls. And those, most importantly, are anticholinergics. So those medications that are typically used to help reduce bladder spasms, right? So your bladder medications, anticholinergics. Antihistamines. A lot of people will use over-the-counter antihistamines for sleep. They impair balance as well. Anti-anxiety medications, or anxiolytics, benzodiazepines. Those are things that should be tapered off if you have someone coming into your facility with falls. And also hypnotics, sleeping pills. So one way to talk to patients about why you need to taper off of sleeping pills is that Insomnia is terrible. I get it. It's horrible to stay awake and watch the clock. However, insomnia has never really killed anybody. It might make your life not unbearable, but it might make your life kind of sucky, but it doesn't kill you. However, sleeping pills kill thousands and thousands of people every year. So as an older person especially, you have to start prioritizing what's more important: getting a good night's sleep or avoiding hospitalizations and potential early death. So there's no sleep disorder, in my estimation, that justifies the use of hypnotics. And by hypnotics, I'm talking about the Z drugs, the zolpidem, so the Ambiens, the Sonatas, all of those medications. If you need to use something for sleep for your residents, then you can try melatonin. It's not super helpful, 3 milligrams to 6 milligrams, but at least it's something. Maybe there's a placebo effect. One thing that I have learned with melatonin is very slow to act, and in some people can take up to 3 hours. So if they've tried it before and it hasn't worked, suggest that they start using it about 3 hours before bedtime, around 7 p.m., and see if it works, and continue to work with them to convince them that it is more dangerous to have a chemically induced sleep than it is to stay awake and watch the clock, especially if they've had a fall. So you want to stop in people with falls. It is your duty. Remember, you took an oath to not cause harm to people, right? It is your duty to refrain from causing harm to people, especially if they've had a fall, especially with an injury, by reducing or stopping anticholinergics, bladder medicines, anti-anxiety medications, antihistamines, hypnotics. Those are the big ones, okay? So I'm very anti those medications. So that group of medications, super important. Another common thing you see when patients are coming in from the hospital, especially if they have dementia, is that they've been started on antipsychotics, and they might have some sundowning and aggression and agitation in the hospital, for which they were started on. Seroquel seems to be a very popular medication. So you have a patient coming in on 12.5 or 25 milligrams of Seroquel at bedtime. That's definitely something you need to stop. You don't need to taper off something that low. If they're on a higher dose, you need to find out why they're on it, and really the reason why you would want to continue Seroquel is, for example, long-time use for schizophrenia, maybe bipolar disorder, Lewy body dementia. Sometimes it's helpful for that. So there might be some underlying reason why you do want to continue an antipsychotic. But for many people that you receive, especially with dementia, an antipsychotic is used for agitation and aggression. It does increase your risk of strokes and heart attacks, and you do potentially cause more harm than benefit in using those medications. Okay? Anticoagulants. Super important, receiving a patient from the hospital, in reviewing their medication list, making sure, especially if they've had a hip procedure, that there is a stop date for their anticoagulants. That is your responsibility, is not the responsibility of the orthopedist. You have to put a stop date, and many times they'll come in with an order for, let's say, Lovenox or Eliquis, and you need to find out whether that, especially if it's Eliquis, whether that's because they have underlying atrial fibrillation or pulmonary embolism or something like that. But if not, if it's simply for DVT prophylaxis, you need to put a stop date at 30 days or so. And by the way, it is important to know that a good study came out recently showing equal benefit using aspirin, 81 milligrams twice daily for DVT prophylaxis in postoperative patients. Equal benefit to things such as Lovenox. So consider using aspirin instead as well. Other things to look at stopping. You may get an elderly diabetic patient on a sulfonylurea. You need to be really, really careful about sulfonylureas and their propensity for hypoglycemia in the elderly. Really shouldn't be using those if you don't have to. Monitor that blood sugar very carefully, and if you start seeing hypoglycemia or overly tight control of diabetes, make sure you discontinue that sulfonylurea and try something else. Proton pump inhibitors. Okay, we all know now that proton pump inhibitors used for extended periods of time do lead to osteoporosis, can potentially increase your risk of pneumonia, kidney disease, and maybe even dementia. So proton pump inhibitors are not benign medications. You're potentially causing harm and violating your Hippocratic Oath if you use proton pump inhibitors for things other than Barrett's esophagus, gastrointestinal bleeding, and recurrent esophageal stricture. But do look up the data on discontinuing proton pump inhibitors. I think it's very compelling. Consider tapering off or discontinuing proton pump inhibitors, especially if they're on something like omeprazole 20 milligrams once a day. If they develop symptoms, think about using famotidine or Pepcid 20 milligrams once or twice a day. Scheduled anti-inflammatories. I think with the emphasis on reducing opioids over the past decade, we've seen an increase in side effects from chronic anti-inflammatory use. And I really feel that scheduled anti-inflammatories are rarely indicated. I would prefer in my patients that they use them on a PRN basis. And if they have a flare-up of their osteoarthritis, perhaps try a 2-week course and then return to PRN use if possible, therefore decreasing your risk of NSAID gastropathy and peptic ulcer disease, as well as kidney disease. And then finally, I want to just talk about discontinuing dementia medications, okay? So dementia medications, especially the cholinesterases, that would be donepezil primarily, that's Aricept, or rivastigmine, Exelon, okay? So lots of people get very attached to these medications because they believe that anticholinesterases have benefit in slowing down the progression of Alzheimer's disease. And the sad truth is that there are no good studies that show any impact of anticholinesterases on Alzheimer's dementia past about 5 months. So the studies that were used to gain FDA approval many years ago were, of course, funded by the drug companies. And they did show benefit from donepezil, for example, in helping patients to achieve better scores on a very intricate test of their cognitive function. That benefit was only seen up to 5 months. After 5 months, no benefit was seen. However, the benefit that was shown in these tests did not actually reflect any, well, let me put it this way. Even though the benefit was seen in those very intricate tests, when you asked the families or caregivers of these patients if there was any benefit from Aricept, there was no statistical difference between those taking Aricept and those taking the control medication. So Aricept and rivastigmine, so donepezil and rivastigmine, have very little benefit for dementia. And if someone has been taking it since they started with mild dementia and now are in advanced dementia, and that quite frequently that's why they're in your facility, there's really no reason to continue donepezil. However, I don't typically start out my relationship with my patients and families by stopping donepezil because, like I said, they can be very attached to it and believe that it's helping them. However, I do look for any potential side effects that donepezil and rivastigmine can be causing. And the thing to remember about these medications is they're anticholinesterases, so that's like a double negative. They're anti the things that breaks down acetylcholine. So they're pro-acetylcholine. They're trying to increase the levels of acetylcholine in the brain. Acetylcholine stimulates the sympathetic nervous system. So those side effects you're going to get from acetylcholine, increased levels of acetylcholine, can mimic overstimulation of the sympathetic nervous system. And as you know, sympathetic nervous system is responsible for those vegetative things that your body does, digestion, for example. And so it will stimulate the digestive system, and you can have sympathomimetic poisoning. Okay, so what is sympathomimetic poisoning? The thing to remember is the mnemonic is SLUDE. SLUDE. S-L-U-D-E. And I only remember this because I had a physiology professor in medical school that spoke with an English accent, and she would say SLUDE. SLUDE. So she would say sympathomimetic poisoning. The mnemonic for that is SLUDE. And what does SLUDE stand for? SLUDE stands for salivation, lacrimation, that's crying, right? Urination, defecation, and emesis. None of these things are that fun to have in overabundance, right? So, but I remember it because of this. I wish I could remember her name. My physiology professor in second year of med school, SLUDE. So sympathomimetic poisoning stimulates salivation, lacrimation, urination, defecation, and emesis. So if you have a patient with dementia that is not eating well, complains of poor appetite, and maybe even nausea, you have to, because again, as a healthcare provider, you cannot cause harm to your patients. You have to stop Aricept. And I don't really believe that and I've never really tapered down Aricept, but you can if you just want to reassure the patient that you're going to do it slowly and in a controlled fashion. Stop donepezil, stop rivastigmine for any kind of GI upset. That gives you an opportunity. The other thing to remember about donepezil and rivastigmine is that they also cause bradycardia. So if you have a patient on Aricept with a slow heart rate, that is your opportunity to stop donepezil. So that's what typically I will do. Because, again, it can be difficult to convince patients or families to stop these Alzheimer's medications, is look for the potential side effects. You're probably going to find one eventually. And then as time goes on, if you work out a good relationship, a trusting relationship with this family, you can continue to visit the issue of the lack of evidence of benefit from Aricept and Exelon, and hopefully can make a shared decision about stopping it. And a little word about shared decision making. Okay? Shared decision making is only appropriate when there is no harm being caused to the patient by your prescriptions. Okay? Shared decision making is always ideal, but if you can't achieve it and the medication that you're prescribing your patient is hurting them, you stop it anyway, right? Because no one can compel you to harm another person. So a family or a patient cannot compel you to prescribe a dangerous medication. I had a patient today that had been on estradiol 1 milligram daily since she was in her 40s. She is 87 now, and originally when I met her just a few weeks ago, because she came into my skilled rehab unit, I said, I noticed you're on estrogen. And she immediately cut me off and said, that's my doctor prescribed that. I want to stay on that. I'm not interested in talking about discontinuing that, because I think she probably heard that in the hospital. And I said, okay, I backed off. Even though, I felt that I was prescribing her a medication that increased her risk for a stroke or a heart attack. I said, okay, just chill and try to come back and revisit it later. I did. About 2 weeks later, after I'd helped her with other things, okay? And she started to trust me. And I talked with her. I said, listen, I am worried that one of the medications you are taking is going to cause a stroke. Or maybe I said something about, I'm concerned that one of the medications you have increases your risk of stroke, okay? I was kind of convincing, but not so dramatic. She wanted to know which medication was that. And I said, Well, it's a medication called estradiol. It's a hormone replacement. Women used to take it, but we stopped it because it increased their risk of heart attacks and strokes as well as breast cancer. And I'm really concerned that it could cause a stroke with you, and I really would hate to see that. And now that we'd had a relationship and she was willing to trust me, she listened. And by golly, I just wrote an order to taper off estradiol. We talked about the potential for hot flushes. And we also talked about the risk and benefit and prioritizing what's important. And for her, not having a stroke was more important than dealing with hot flushes. So she was totally into stopping it. So anyway, you sometimes have to use a little bit of finesse in discontinuing medications. I have talked for over 20 minutes. I apologize for this being so long. But anyway, I just wanted to give you all a little push to stopping medications. Kudos to you that are already doing it. Kudos to you that want to become more geriatrician-ish and take opportunities such as admissions and recertifications to look at that med list and make sure that you are not harming your patients by prescribing them unnecessary or potentially dangerous medications. All right. See you all later. Bye.